I'd like to acknowledge Dr. Bernal. Him and I have worked together for these last years doing these procedures. We do mainly clinical work. As was my previous lecturer said, most of this is done offline and then imported into the PACS system. We don't have a robust post-processing computer that's embedded into PACS. So the images that you'll see, we do on an offline computer, and we import it into PACS with screen capture after they're done. So basically, just to review briefly, FMR uses paramagnetic effects of deoxyhemoglobin to provide an endogenous contrast of the brain. And so the region that's performing a task has increased blood supply, and so using echoplanar bold imaging, we can see functions both in motor, visual, and cognitive functions. And in our instance, we use it mainly for surgical planning, both for tumors and epilepsy, but we are increasingly using it to look at cognitive functions as well. So just a little bit of definition of terms, and the terms that we use in functional MR is time points, and one time point equals 14 slices through the brain. This is done in 2 seconds with the echoplanar bold technique. We generally use from 20 to 30 epochs, which is 10 to 15 time points per epoch, and I'll show you what we mean by epochs. And in general, the series we do are 100 to 150 time points. So if you do the math, each of these takes around 2 or 3 minutes. 3T versus 1.5, I will tell you, we do it at both. The pulse sequence isn't a whole lot different. The TE is a little less. We keep all of our TRs at 2. And I think that for most of our clinical work, we haven't seen a big difference between 1.5 and 3T. So just to show you the time point, epoch, cycle, how all this works, in general, we are doing in 10 time points now, so this slide's a little old. We've changed over time, and we've looked at different time points and different TRs, but I'm showing you what pretty much works for us. So a TR of 2 works. Time points, we do, like I said, within 2 seconds, we do 14 slices. So what we have is then we take and do, for each task, we usually do 6 epochs, and we do an on epoch and an off epoch, and we repeat this 3 times, and this gives us this block paradigm technique, and this is what we do when we ask the patient to do a task. We'll ask them to do something, do a rest, do something and do a rest, and then the post-processing, we take all of the on and we subtract from it the off, and we get the positive bold. If you want negative bold, you reverse it. You can do either. And so just like my predecessor, we, as opposed to having a homegrown process, we use FSL. That's freeware. It's available on the web. It's download. There's not a lot of instructions with it, but it is what we've used, and it's very robust, and it allows post-processing in many different ways. More recently, we've also used BrainLab, which is a neuronavigational tool. Their software is fairly robust, and it also lends itself in that you can do image co-registration, and it allows you to work with the neurosurgeons to co-register these functional MR images on the anatomic. So the methods we use task-oriented, which I'll show first, and that's pretty much what we've done for the majority of the years. And we do this both in sedated and non-sedated patients, and then which is increasingly being written about and utilized, and we've started to use, which is called resting state FMR, and I'll show you some examples of that as well. I think that the resting state is interesting in that we're looking more and more at cognitive and at neuropsychiatric disorders, and that's where we found this to be interesting and helpful. So a little bit of a review. I think I presented at SPR back in 2008, and some of this is a little review of our task-oriented FMR. But what we looked at primarily is motor, auditory, and I differentiate auditory and language, visual and memory, and then some executive functions such as motor and cognitive inhibition. So this was shown earlier. These are the Brodmann areas of the brain, and just this is expressive language, 45 and 44. Receptive is mainly 22, Heschel's gyrus, and this was described a long time ago in early 1900s and has significant applications ongoing in the work we're doing, looking at the different cognitive functions. So what do we have in our toolbox? Well, we'll go through a little bit of, and don't have to worry about reading all this. It's all in the syllabus, everything that we do. But for the motor and sensory, we've used different paradigms in the past. The ones that's highlighted is a squeezing sponge. It seems to work the best for us now. Training the patients to tap their fingers, it's difficult, and if you just simply have them squeeze the sponge either at the same time or alternatively, alternating, it works for us and is in general what we use for the motor functions in the patients that are not sedated. This DAGA is what we do to try and map the oral area in children. It will get bilateral activation. It also can be extrapolated to using a pacifier and sucking in sedated infants. And then if the patient is sedated as well, we generally now will move the hand. We actually rub the hand, and we extend the fingers of the hand while the patient's in the magnet. We are working on something to try and automate that, but currently we have to climb in the scanner if the patient needs motor. So what do we get? Well, this is motor activation, and this is from squeezing a sponge, and the rest is just not squeezing the sponge, and you can see nice activation here in the motor cortex, and we sometimes get some sensory, but you can see pretty much in the premotor cortex the activation that we get with this paradigm. And obviously it's helpful if you have a big tumor like this, big oligodendroglioma in the dominant hemisphere. You can map motor, and we do this in our post-surgical tumor planning. We also have reorganization, which, as I said, we have a large seizure patient population, and I think that in seizure patients, many of these have anatomic and/or these disorders have been with these children since birth. It's important that you do map motor and language because there can be reorganization, as I'll show you several cases. So this was a child that we had, this was an earlier paradigm where he was tapping his left finger, and you can see that his motor activation actually is transferred to the left cortex. A little bit about language mapping, and this is our, eloquent area. I think it differentiates us humans from the rest of the animal kingdom, and it's very important that you don't resect dominant language area trying to cure seizures. So we do a couple of different paradigms. Auditory, we have mother's voice recorded, and we turn it on and off with the task and the rest phase. And more recently, we've created a movie. This movie is Ice Age. Children seem to like it. And we have different portions of the movie played during the on and the off task. During the on task, there's language that's presented. During the off task time, there is just, you can hear natural sounds like the ice cracking and all that, but we take out the language. And it's become a very good tool for us. So if the patient so we have to scale the tasks according to the age of the patient. So for the movies are the younger children, and then in the older children, we've done different tasks. You can have them listen to a story. This is very sensitive for us. 90% we get activation. We were doing a task. The NIH had a paradigm where you listen to a story and then you play in the rest phase the story in backwards language, and it subtracts out the primary auditory cortex, but we still feel that we only got activation in about 70%. So I'll show you some differences there in a minute, but we feel that just the listening to task is more sensitive. And in the older children, antonym production, they think of words that mean the opposite, and the control is quiet. And or an auditory descriptive task where they press a button when the sentence that's presented matches a true word, and then the rest stage is they will press the button when they hear a tone. So this is our toolbox along with the movie, and we try and use at least 3 of these to map language. So this is just what I was talking about, the different rest states. This was reading the story backwards, so you do see it subtracts out the primary auditory cortex, but Heschel's gyrus here, which you see posteriorly, you see, but you can see it without doing that. And it seems like we had better luck with using without the backwards reading and just having quiet, so that's what we currently use. This is antonym production, so according to the Brodmann areas of 44 and 45, the antonyms that we use, you can see some secondary auditory in 22 and 45 on the dominant hemisphere, so we can see expressive and receptive language using these tasks. So as I said, it's best done when we do a group of tasks, and we do usually 3 of the 4 of these when we have a cooperative patient, and this just gives you an idea of listening to the story where you can see pretty much area 22 or the receptive language. Antonyms, you see Broca's region here, both with antonyms and the auditory descriptive tasks. So another example of a patient with seizures. We see a lot of these children, and unfortunately with medically refractive epilepsy, we operate on a lot of these children. As you can see here, this area here of the brain has, on the left, there's a diffuse polymicrogyria, and so you can see that in this child with the diffuse polymicrogyria, when we did the language mapping, his secondary auditory cortex was on the right, and in fact he had a hemispherectomy on the left. And he had some post-op mutism, but in fact went to full recovery without language impairment. And so this is what we're looking for a lot of the times, is language dissociation. So if you have a right-handed child, it's not always 100% in these children with seizures that they're going to have left-sided dominance. And so what we usually see, if there is a dissociation, is that the receptive area, or 22, Heschel's gyrus, is the area that will switch more readily than the expressive area. And this is one case in point. To show you another more recent one that we just saw, this is a subtle area of cortical dysplasia in the mesial left temporal lobe. This child had absence seizures, and when we did the language mapping, you can see here that there is the receptive language is on the left, and in this case, Broca's was switched to the right. So this is important prognostication. We do work closely with our neurosurgeons and the epileptologists and on these types of patients. So going from language to visual, we use homespun goggles. We put the goggles over the patient's eyes, and we turn it on and off with the rest and the task state, and or we put a screensaver in there, and we put a screensaver in the magnet, and we can turn it on and off as well. And this is a 10-year-old with seizures. Again, you can see there's fairly diffuse, at least parietal occipital dysplasia, there's neuronal heterotopia, and so in this child, they could go on and resect this safely. We mapped out the visual cortex to be exclusively on the left side, which was the normal, or the more normal side. And last but not least, memory tasks. We have done some memory tasks as well. We've tried several different ones. The visual descriptive tasks, we ask the child, we present either an indoor or an outdoor scene to them visually, and they press a button when they see the indoor scene. And then for the rest state, we have a vertical line placed on top of abstract, and they push the button when the line's shifted to the left. That has been our mainstay. We've tried navigation tasks where the condition will recall trying to get, say, from home to school. I don't know about Miami, but it doesn't seem to work nearly as well. And some of what we get are these activations in the parahippocampal region you can see here. And it's usually bilateral, but usually more in this side on the right, on one side versus the other. And there's been publications about this. This is a child that actually had been mapped using this navigation task, and you can see that the navigation task shows the parahippocampal gyrus more pronounced on the left. This child had a right-sided area cortical dysplasia, and if the area of the activation is less ipsilateral to where the resection is going to be, the memory deficits are much less. And this was reported by Jansky and basically says that if there's activation in the mesiotemporal region ipsilateral to where the epileptogenic region is, the results are much better. A couple other tasks we do is motor inhibition and or color Stroop tasks. We find these useful in patients with ADHD. The motor inhibition task, we have a letter that's displayed on a screen every second, and they shouldn't press the button when they see the letter X. These children with attention deficit, really it is a problem with motor response. There's also a color Stroop task where they need to look at colors which are presented into the magnet on the screen, and they have to mentally name the font color, which is not so easy to do. You tend to read it, and it's hard to say that this is yellow because you're reading red. So we do that as the active task, and we compare that with where they are matched. So what we did is we looked at a bunch of controls, and so what we found in general in normal subjects that the right frontal area of activation is seen with this motor inhibition task, and with the color Stroop task, this is seen in the left frontal area. And I think that that's been helpful for us because we haven't seen this so much with the ADHD children, but once they put them on the Ritalin or whatever, it becomes more what looks like this normal control. So that's kind of our toolbox for children that have that are able to cooperate with us, although we've been doing sedated patients as well, and I just wanted to show you a little bit about that. Obviously, we have to do passive paradigms, and those consist of listening to the story in mother's voice, the flashing lights, and the somatosensory with rubbing and extending the hand. So the Z scores that we search for are lower than with children that are not sedated. Also, you need to switch the post-processing to look for negative bold for the visual task. The negative bold response is well known and well described in the literature. The reasons for it are many and not 100% understood, but just when you post-process these sedated children, you need to look for negative bold. So we reported on this in 2001, And we said that using older types of sedation, we had a 68% response for auditory and a 90% response for visual. We have modern sedation techniques now. We have an anesthesiologist in the department. We've tried many different drugs, but we have reported recently our scheme, which to us is very helpful. So what we do is we start with the patient. We do this at the beginning of the sedation, and we'll use Precedex to start, and that's very good to look for auditory and motor response. We'll then put in a resting state sequence, and then we'll use propofol to look for the visual. So we'll actually turn, with these analgesics, you can turn them on and off, so we do. We turn on the Precedex, we get through the auditory and the motor, and then we'll turn on the propofol after a rest where it clears, where we do the resting state scheme. So we get 90% activation with Precedex and 90% activation with propofol using these techniques, and so it's fairly robust. This is a motor task that I want to show you. Usually the activation is more motor and sensory as opposed to the patient that's non-sedated where you see more of the precentral cortex. Here you get both. And you can see nicely the negative bold in the visual cortex, and this is auditory. So that's what we do. That's mainly what we do in the sedated children. Once in a while, you do get not only activation in Heschel's gyrus, but Broca's just from doing a passive paradigm of listening to mother's voice. So as alluded to and mentioned a little bit through the talk a little bit about resting state, and there's been a lot written about this. When we first started doing FMR, we would see a couple articles a week. Last week I looked on PubMed, and there was over 100 articles on FMR published that week. And it's been that way for quite some time. So it is exploding, and it's in the hands of many people, as far as psychologists and psychiatrists, and some of this is using these components. Now, we have a pretty lengthy bibliography in the syllabus, and a lot of these techniques will be put, you can read about them there. We're going to talk mainly about independent component analysis, but I'll give you an overview of in fact, what this looks at. And this post-processing takes maybe 10 or 15 minutes. If you go to Reho and that type of thing, we're looking at hours of post-processing. So, and then we'll talk a little bit about the end of the talk about some of these things. So, what the resting state does is it actually samples, we take 200 time points, and we take all of those time points, and then we post-process them together. And what the post-processing does simply is it looks voxel by voxel at all of those time points. So that's 200 time points times 14 slices, that's 2,800 slices, and our computers start to freeze up around 3,000, so that's kind of why we chose 200 time points. So the pulse sequence takes 6 minutes, 6.5 minutes, and it searches through the brain for similar areas of timeline graphs. So it looks along the timeline. The Reho can also look for amplitude, and you search for similar areas. So what this does is it not only looks for similar areas in the brain that have very similar timelines at certain hertz or megahertz frequencies. It also, if the timelines are similar, then you can look at connectivity as well. So and so then the question is, well, why do areas of the brain light up? And the ones that light up are areas that we recognize, meaning visual lights up, and that's the $64,000 question. We're not quite sure, but there's no paradigm needed. There is both temporal and spatial correlation that we can look for, and we can do this under sedation, and as I said, it can show connectivity, and it can also look at other physiologic cyclic events, such as CSF pulsation, and in the future, I think this may be helpful as well. So I think we went through this. It's a rather long sequence. It samples these components at different areas, and it's from 0.01 hertz to 0.1 hertz, and it looks at these neural rhythms in the brain. So usually these areas are bihemispheric in distribution, and indeed it may show connectivity. So this is kind of what you get on the FSL post-processing. So this is an area that when we sample it and we look at, you have to divide this is log, but this is at 0.2 hertz, we see areas that activate in what we understand by history to be the visual cortex. And so this is the timeline that's searched for at all these different voxels, and it happens to be in these areas of brain, this timeline is the same. It's identical, and that's what the software is searching for. And so we've come to realize with this post-processing that we can see, these are the typical, what we call, these are the typical areas that we see when we search in this way, and these are displayed on these echoplanar bold images. So we see areas that look like visual cortex, the auditory cortex regions. We'll talk about this a little bit. This is the default mode, and there's a posterior and there's an anterior default mode where you get the parietal regions and the posterior cingulate regions, and then there are some areas on the left and right side in the frontal region. But this we've found to be consistent, and so this is a kind of a validation. This is the same patient that had the conventional task-related FMR, and you can see activation here bilaterally in the region of the auditory cortex. This is using this resting state, and you can see activation as well. This is just the block paradigm, but this is this specific timeline, 6.5-minute timeline that's consistent in these areas at this region of megahertz. So what are some of the clinical applications? And you'll want to read about it. That's a brief survey. My time's running out, so I want to show you, but this is a patient that had hemimegalencephaly, as you can see on the left. He was hemiplegic, could not cooperate, and this was the resting state that we see, and we see all of his motor activations on the right. So it's helpful, and it certainly gives the surgeons more confidence when they go in to resect and do a hemispherectomy. Now, I mentioned the default mode, and this is something that is being written tons about in the neuropsychiatric literature, and it's activated while the patient is just at rest thinking about the outside world. We've seen that what happens is when you have a cognitive load, this default mode gets less. And that's what all of us do with cognitive work. There is a lessening of this default mode seen. And just to give you an idea, so this is the activation we see with the resting state with the posterior default mode. And then what we see here in a normal volunteer, you see that this is done in resting state, and then we have them do a task, and you can see the default mode tends to be less. Exactly why this is, we're not sure, but it's what we've seen. Now, you need a large cohort of normals to be able to know what's more and less and all of that. And this is a child with a psychiatric patient with visual and auditory hallucinations, and you can see here that his default mode is asymmetric, which we don't expect. And we're starting to see in some of our neuropsychiatric patients things like this. It's one more pulse sequence we can do in the FMR, and we're looking at them all. There's a bunch of things that have been described, and don't worry about reading all of this. It'll be available for you, but it seems that patients with neuropsychiatric disorders, they don't see this deactivation in the default mode, and this has been described with ADHD, schizophrenia, autism, and some bipolar disorders. So we're trying to look at cohorts of these. Now, like I said, you need normative data, and fortunately, the Chinese have helped us. They have put online a 1,000 patients that they've looked at with this resting state. It's released. It was recently in an article that was in AJNR, and in fact, they have a cohort of children as well. There's only 200, but 200 of this 1,000 are children, and you can get this online and download it, which we've done, and we're looking at that to give us this normal cohort to be able to tell the difference between what a normal default mode and a diminished default mode, and so this has been very helpful. Another thing that we're looking at, which has potential, is this connectivity. Now, here you're going to have to flip things because left is actually on your left as opposed to right. This is the way this post-processing algorithm works. But we can take a point of interest and seed it, and we can then see what looks connected through this resting state algorithm. So here we've seeded the area 22, and you can see on the left side of the brain there's similar areas or connectivity in Broca's region. If you do the same on the opposite side, which is the patient's right side, then you don't see this area of connectivity. So the implication here is that, in fact, we can perhaps, with resting state, be able to tell in a sedated patient, for us, what the dominant, not only receptive and expressive areas are. We usually only get receptive when we do our sedated patients. Again, just the opposite. We've done the same thing looking at the Broca's region in the right, and this is the patient. I'm sorry, this is the patient's left, and this seed point shows on the left the activation here in receptive language seeded from Broca's, and not on the right. Pharmacology FMR. We have some applications here, and we're using some resting state as well. I'll just show you one example, but as stated earlier, patients with ADHD on the Ritalin type of drugs, you can see different areas of activation. This was a child here that we did resting state, and we can see total dissociation of the expected areas that we would see, and then once he was on anti-psychedelic drugs, much more normal when we followed him up after 6 months of therapy. Another thing that we are looking at is epileptogenic focus detection. It's been done ictally by mistake with non-clinical seizures that occur in the magnet, but more importantly, intra-ictally, where you have consistent areas that have been determined by EEG, and which we can also map. What happens is you need to have MR-compatible leads. These leads will then trigger the time point and the pulse sequence, and the holy grail is to be able to look at epileptogenic focus using FMR. We haven't really done that. It's been reported though, and I just wanted to show you this. And we are working on getting this project started at our place. It's just the leads and getting it all within the magnet has not been easy for us. And just one brief mention of fetal MR. I know we're going to have a lot of good talks on fetal MR a little bit later in the course. We have tried the resting state on a couple of our infants. This is one that we did, and just to show you, this is this patient where we did resting state, and in fact, this is probably the default mode, but we can see this in the fetuses as early as 22 weeks. So with that, I still like to think that the FMR of pediatrics is looking into the minds of our future, and thank you very much for your time and attention.